Good afternoon. On behalf of my co-chair and I, Professor Silke, it is our great pleasure to welcome you to our latest ESO Guideline Webinar. Led by Professor Guillaume Turk and Prof. Simona Sacco, our ESO Guideline Board have been working extremely hard to develop new guidelines on behalf of our members. Last year, the Guideline Board and our colleagues produced an average of almost one new guideline per month. And so far, we're on track to produce a very similar output this year. So this is fantastic work, and we thank everybody involved very much. ESO guidelines are produced to the absolutely highest standards using rigorous grade methodology and selecting only the most rigorous evidence from randomized clinical trials and other high quality studies. Today's guideline, as you know, is our new ESO guideline on stroke in women. And it's my pleasure to hand you over to my co-chair, Professor Walter, to tell us a little more about our content this afternoon.
Thank you, Peter. Also from my side, a very warm welcome to this ESO webinar. We've got an interesting program lying ahead of us with well-known speakers addressing topics related to clinical questions like risk factors and undertreatment of women with stroke, but also to challenges of stroke research with women, before we then hear details of the new ESO guideline on stroke in women. To the audience, please put all your questions into the Q&A and we will address them after the presentations. It is now my great pleasure to introduce our first speaker, Theodore Karapanayiotides. Theodore is an associate professor of neurology at the Aristotle University of Thessaloniki in Greece. He is the ESO representative at the board of the European Society of Cardiology Stroke Council and a member of the ESO Committee Brain and Heart Council. His main interests are stroke and risk factors, ultrasound and reperfusion syndrome post-carotid surgery. And now we are looking forward to hearing more about gender-specific risk factors in women. Theodore, the floor is yours.
Thank you very much, Silke, and thank you very much for pronouncing my last name correctly. I would also like to thank the Guideline Board Committee for the very honoring invitation to give this talk, and I would also like to thank all members of the Stroke in Women Guideline Group, and in particular Christine Kremer and Valeria Caso, who spared no efforts and time during the long course for the completion of these guidelines. Now, let's start with this Gustav Klimt painting titled Hope 2, which depicts a pregnant woman, most probably a queen, dressed in this magnificent gown and surrounded by her ladies of the court who keep meditating or perhaps praying in an attempt to avert any threat that may endanger the mother or the new life. We even see a skull on the woman's abdomen. This painting epitomizes that women are magnificent creatures with extrinsic and intrinsic beauty who possess the gift of giving life, but who are exposed to risks inherent to their gender. And now, after this brief philosophical artistic intro, let's move to the body of my talk. Although the majority of stroke burden in women can be attributed to traditional vascular risk factors that occur in both men and women, there are several stroke risk factors that are specific to women. In particular, these gender-specific risk factors are endogenous and exogenous sex hormones and pregnancy with a puerperium. We will deal in detail with these risk factors unique to women. However, please notice that even traditional risk factors may be potentiated in women, either because the strength of association is higher in women or because the frequency and therefore the population attributable risk is higher in women. This potentiation may apply to hypertension, AFib, diabetes mellitus, dyslipidemia, depression, and migraine. Let me remind you that female sex is part of the CHA2DS2-VASc risk assessment score for AFib, but this is the subject of a different talk. We will now start with pregnancy. Pregnancy is associated with myriads of physiological changes in the woman's body, and in particular with many changes affecting the circulation and the hemodynamic status of the mother. Speaking of cerebral arteries, these changes are structural, affecting arterial wall thickness and composition, but they're also functional, affecting contractility and endothelial reactivity. In this graph, we can see the major hemodynamic changes during pregnancy with a significant increase of the cardiac output, the considerable decrease of the systemic vascular resistance, and the restoration of these variables to baseline during the postpartum period. We should also keep in mind that during pregnancy, the equilibrium between coagulation and inhibition of coagulation fibrinolysis is shifted towards the activation of the coagulation cascade. So to place it correctly, pregnancy is a physiologic prothrombotic state or a state of accelerated but compensated intravascular coagulation. The incidence of stroke during pregnancy at the puerperium varies across different series from 20 to 90 cases per 100,000 pregnancies. If we stratify stroke incidence by type of stroke and by time point, we see that the vast majority of pregnancy-associated strokes are peripartum strokes occurring within 1 to 2 days before and after delivery. And this is true for all types of stroke, for brain infarction, for ICH, and for subarachnoid hemorrhage. You see that practically all strokes occur the incidence of stroke during pregnancy is very low during the whole pregnancy, only to rise steeply just before delivery and then to decline again 24 hours postpartum up. It seems that stroke rate during pregnancy parallels the risk of accident during a flight, where most of the accidents occur during takeoff and landing. Furthermore, apart from the risk of stroke during pregnancy and the postpartum period, an expanding body of research has shown that complications of pregnancy like preeclampsia, gestational diabetes, and pregnancy-induced hypertension are associated with higher risk for future cardiovascular disease and stroke beyond the childbearing years than among women without these disorders. For example, across several series, women with a history of preeclampsia have a 2 to 20-fold increase in risk for development of chronic hypertension. And as we can see from this recent publication from a cohort study in Finland, at least 50% of women who presented gestational diabetes mellitus will develop diabetes mellitus in later life. Both hypertension and diabetes mellitus are major stroke risk factors, as we know. Two meta-analyses, one from the UK and one from Canada, from the McMaster, showed that women with a history of preeclampsia have almost twice the risk of stroke compared with women with uncomplicated pregnancies. Despite these accepted associations, it may be decades before women with a history of preeclampsia or gestational diabetes mellitus have formal cardiovascular risk factor screening and treatment, thereby accumulating atherosclerotic burden in the meantime. Now, we will leave pregnancy and we will examine the role of endogenous sex hormones as gender-specific stroke risk factor in women. We know that estrogen levels fluctuate dramatically in women during the menstrual cycle and then drop dramatically in the menopausal transition and in postmenopause. In data from the Copenhagen City study, neither high nor low estradiol levels were associated with increased risk of ischemic stroke in premenopausal and in postmenopausal women. Only premenopausal women, and only those in the lowest 10th percentile of estradiol, had a twofold increased risk of ischemic stroke. You can see this on the left-hand side over the bottom panel. But this association was based on small case numbers. On the other hand, testosterone levels are more stable than estrogen levels across the lifespan in women, and the investigators found no association between high or low testosterone levels and risk of stroke in premenopausal and in postmenopausal women. Low dehydroepiandrosterone levels have been associated with increased risk of ischemic stroke, with women in the lowest quartile having a risk for ischemic stroke increased by at least 40 to 50% after adjustment for other risk factors. And there are also data suggesting that the dihydroepiandrosterone is inversely related with stroke severity and mortality. Concerning age at menarche and stroke risk, the Million Women study from the UK showed a U-shaped relationship between age at menarche and cerebrovascular disease. Women who experienced menarche at age less than 10 years were at higher risk of developing stroke in later life, as you can see here, compared with those age at menarche at 13 years. And the same way, women who had menarche beyond the age of 17 years were also at higher risk of developing stroke. We discussed about the age at menarche. What about the age at menopause? In a recent meta-analysis, investigators reported that early age at natural menopause, that is menopause onset before 45 years, was associated with a 50% higher risk of cardiovascular disease. However, this was not as evident for cerebrovascular disease. This was marginally non-significant, as you can see on the right-hand side. And a similar trend may also apply to surgical menopause. But perhaps the clue is not just in the age at menarche and menopause, but in the total duration of a woman's reproductive lifespan. In the prospective cohort of Nurses' Health Study, a shorter duration of reproductive lifespan, that is less than 30 years, was associated with a higher risk of stroke, as well as a higher risk for cardiovascular disease. However, these effects were likely driven by earlier age at menopause, either naturally or surgically. Now, let's move to a major issue, and that's the influence of exogenous sex hormones on stroke risk. COCs, that is combined oral contraceptives, comprise both estrogen and progestogen. They're thrombogenic and historically have been associated with increased risk of cardiovascular disease. According to this relatively recent meta-analysis by the Cochrane group, COC users were at increased risk of myocardial infarction or ischemic stroke compared with non-users. The relative risk was 1.6, and these relative risks were similar for myocardial infarction and ischemic stroke. Oral estrogens have a dose-response association with risk, and doses have declined since their first introduction in the 60s. Most COCs now contain less than 50 micrograms, and some contain as low as 15 micrograms of estrogen. We can see from the same Cochrane meta-analysis that the risk of myocardial infarction or ischemic stroke increased with increasing doses of estrogen, from a relative risk of 1.6 for preparations containing 20 micrograms of estrogen to a relative risk of 2 for preparations containing 30 to 49 micrograms, and to a relative risk of 2.4 for preparations containing more than 50 micrograms of estrogen. On the other hand, progestogen-only hormonal contraceptives have not been associated with increased risk of ischemic stroke, although data are limited. This forest plot comes from meta-analysis up to 2009, and this table over here is from the more recent Danish cohort by Lidergaard and colleagues confirming these findings. By contrast, non-oral methods of delivering combined hormonal contraceptives, including the vaginal ring and contraceptive patches, seem to have the same risk as oral contraceptives. The administration of exogenous sex hormones in the context of other risk factors may create an explosive combination. The risk of stroke in patients with migraine with aura is increased twofold. Women with migraine who also use CFCs have a 7-fold increased risk of ischemic stroke, whereas women with migraine with aura, COC use, and who are active smokers have a dramatically elevated 10-fold risk for stroke. And this is a beautiful example of the interplay between conventional risk factors and gender-specific risk factors in women. Now, we'll move from birth control pills to hormone replacement therapy in postmenopausal women. In the Women's Health Initiative, women randomized to combined estrogen plus progestin for primary prevention had a hazard ratio of 1.3 for total stroke and of 1.44 for ischemic stroke. In the Women's Health Initiative trial of estrogen alone, women randomized to active therapy had a hazard ratio of 1.4 for total stroke and of 1.5 for ischemic stroke. The figures here show the cumulative hazards of ischemic stroke for women in the estrogen alone and estrogen plus progestin trials. In the E plus P, in the combined trial, the actively treated group began to show an increased risk of stroke by year 2 of follow-up, whereas in the estrogen alone trial, the increased risk in the actively treated group did not appear until after 4 years of follow-up. Although some data suggest an association between timing of hormone therapy and coronary heart disease, time since menopause is not associated with differences in stroke incidence in either observational studies or in clinical trials. Analysis of data from the 2 trials of Women's Health Initiative showed that timing of initiation of HRT since menopause impacts on coronary heart disease risk, with women starting HRT more than 20 years after menopause having the highest risk. On the contrary, the risk for stroke was consistently high regardless of time since menopause. And also data from the Nurses' Health Study suggest that, as in the case of birth control pills, there is a dose-response relationship between the dose of oral conjugated estrogen and stroke, with no increased risk for a dose of 0.3 milligrams, 1.54 at 0.625, and 1.6 at 1.25 milligrams of estrogen. HRT does not seem to work for secondary vascular prevention either. The West study, the Women's Estrogen for Stroke trial, in women with recent mild ischemic stroke or transient ischemic attack, found no significant effect of treatment with oral estrogen on risk of stroke recurrence, even there was a trend towards harm. The primary outcome was death and non-fatal stroke, and there was no difference between the 2 arms. Fatal strokes were, interestingly, numerically, but not statistically higher, and this was mainly driven by ischemic strokes. Now, concerning the route of administration, limited data are available for transdermal estrogens, which have been associated with lower risk of venous thromboembolism. In a population-based study from the UK, current use of transdermal hormone therapy was not associated with an increased risk of stroke. However, when the dose was examined, low-dose transdermal estrogen, less than 50 micrograms, was not associated with risk, while high-dose transdermal estrogen was associated with increased stroke risk. And in this study, there was also a dose-dependent stroke risk increase for the oral route, as we have previously mentioned. So, bottom line, specific considerations that include endogenous hormone levels, exogenous hormone therapy, pregnancy, and the peripartum period change the risk of stroke for women, as well as the optimal stroke prevention strategies. We need further research to determine whether risk prediction models should include risk factors specific to women, including hormonal and reproductive exposures. Well, I started my talk with art, and I will finish it with art as well. This quote belongs to William Congreve, an English writer of the late 17th century. Women are like tricks by sleight of hand, which to admire, we should not understand. I cannot agree more with Mr. Congreve. However, by adapting the quote to our context, I will say that understanding stroke risk factors unique to women and their interaction with traditional risk factors is a research priority and a prerequisite for understanding stroke in women. Thank you very much.
Thank you, Theodoros, for a wonderfully clear and well-presented overview of the data. And thank you also so much for keeping to time. So our next speaker is Professor Zuzana Gdovinova, my apologies. Zuzana is the head of the Department of Neurology at University Hospital Louis Pasteur in Košice, Slovakia. And she is president of the Slovak Neurological Society and past chair of the Slovak Stroke Society. Her main academic interests are stroke and dementia. And today she's going to give us a presentation on undertreatment in women. What are the main challenges in stroke prevention? Zuzana?
Peter, thank you for introduction me, and it was an honor for me to be a part of the group working on women guidelines, and I hope that our results will help our colleagues in everyday practice. To my lecture today, we heard in a previous lecture about the risk factors for stroke in women. I will continue with the next one. Please, next slides. Next. Next, what we could do to decrease the number of stroke. Please, next slide. To decrease the stroke, the severity of stroke, to decrease mortality, and to improve the quality of life of women. I think that the answer is very simple. We know the risk factors, so we should treat them, and we should continue in improving it. Next slide. Next slide, please. Thank you. What about, this was the goal of Tracy Madsen, who studied the differences in the risk factors in women and how they are treated. So what was found? They found that hypertension is the risk factor in older women, but we can see that mainly older women are less likely treated by antihypertensive drugs. We know about atrial fibrillation, that it is the risk factor of stroke in women, but again, women are less likely to be prescribed oral anticoagulants, to have cardiac ablation. And about the next risk factors, the data about diabetes and the dyslipidemia are conflicting, if there is difference between men and women or not. But again, in women, women are less likely to be prescribed statins, and they have a worse control of the cholesterol. Next slide. As I mentioned, atrial fibrillation is the risk factor for severity of stroke, for mortality. And we can see on the right side that the highest risk factor it is for stroke. When we want to decrease the risk of stroke in patients with atrial fibrillation, at first we should, or patient at first should visit a doctor. Next. Next, please. Patient should visit a doctor, and it was the goal of the study of authors who presented data about Medicare beneficiaries in the US. And we can see that again, women less likely visit electrophysiologist, cardiologist, and the consequences are clear. When they did not visit the doctor, the prescription of rate control medication, rhythm control medication, catheter ablation was again lower in women, and again women less frequently used anticoagulants compared to men. Please, next slide. Registries are a very useful source for data to study patients from real life. We know that in randomized control trials, we have patients who are selected, and they are not the same as we have in the real life. And from National Cardiovascular Data Registry in the United States, the colleagues analyzed patients with newly diagnosed atrial fibrillation. And the patients who were included in this analysis were patients with more severe stroke, as we can see from the CHAT score. Next slide. And I think that the results were not surprising, because we know from everyday life that patients with atrial fibrillation are undertreated with oral anticoagulants, and it was the same in this analysis. And 40% of patients used aspirin alone, even though they met the criteria for oral anticoagulation. Again, despite the factor that women have atrial fibrillation as a risk factor more frequently than men, women were less likely to be treated by oral anticoagulants compared to men who had a higher odds ratio for treatment with anticoagulants as the prevention of the stroke. Next slide. One problem is that women are undertreated with oral anticoagulants, but the second problem is that in a lot of patients the dose of the anticoagulants is decreased without any reason. And the problem with women was about the dabigatran, because in some studies it was found that there are higher levels of plasma levels of dabigatran in patients treated with dabigatran, and that is why it was a recommendation done by some authors to reduce the dose of dabigatran in women. But the analysis which was realized in Canada compare patients who were treated with aspirin and with dabigatran, and we can see results. Next. When they compare patients treated with warfarin and dabigatran, there was no difference between patients. What about the stroke events? But they found that dabigatran has less frequently bleeding complications, what is not surprising. We know it that new oral anticoagulants are more safe than warfarin. But what was interesting, that lower dose of dabigatran had higher risk of bleeding compared to dabigatran 150 milligrams. And we can do conclusion from this that not plasma level of dabigatran is important, but it is important the outcome. And we can see from this study that outcome of patients treated with higher dose of dabigatran was better than patients treated with lower dose, and there is no reason for the reduction of the dose of dabigatran in women for future. So not only drugs, but also the dose of the drugs is very important for the prevention of the stroke. Next slide, please. Here we can see the representation of the women in the randomized control trial, and the women are blue in this picture, and we can see that they were underrepresented in all randomized control trials. And it is the question, is it only in randomized control trials, or is the real life? About this will be the next lecture. And now I will speak a little bit about the arterial hypertension. Next slide, which is the second risk factor of stroke in women. On the left side, you can see that the distribution of the hypertension in different ages is similar between the men and women. Maybe women are a little bit have a little bit higher prevalence of arterial hypertension. But the interesting is the right side, when we can see how arterial hypertension is controlled in the patients with hypertension. And when we can see the right column, the best treatment of hypertension in women was between 40 and 59 years of age. But we see that in women over 60, the hypertension was worse controlled than in younger patients. And we know that the older women are at higher risk of the stroke. It is the question, what does it mean over 60? Because over 60, it can be 70 and it can be 90 or 100. It was not analyzed in this article. But because it is the question if it is influenced only that women were very old and in the terminal stage of the disease, or they were younger, because 70, 80 years of age women should be treated as it is recommended. Next slide, please. Cheryl Carcel is a doctor who deals with differences in women a very long time, and she published a lot of articles on about this topic. And also in this article with the co-authors, they presented sex differences in treatment and outcome after stroke. They analyzed nearly around 19,000 participants. And next slide, please. And they analyzed 5 randomized control trials where representation of the women was about 40%. And again, the results are not surprising when we compare it what we heard before. The medication at admission was worse for women when we compare anticoagulant, antiplatelet, glucose lowering and lipid lowering drugs. You can see on the graph that women were less likely treated like men. And what about the secondary prevention? Then in secondary prevention, antiplatelets were used similarly, but antihypertensive agents were less likely used in women compared to men. And next slide. What about the other results? Women had higher survival at 3 or 6 months, but with the worse quality of life. And I think that it should be our goal not only to prolong survival, but to improve the quality of life. And the quality of life was studied in the next study. Next slide, please. Again, we have the data from the registry. The Get With the Guideline Stroke registry is a US registry of the patients with the stroke. And they predefined performance measures for measurement of the quality. 3 of them were for acute treatment, and then 4 discharge performance measures. Women who were included in this analysis were older. They have a higher history of atrial fibrillation and arterial hypertension. And what is the result of this quality analysis? Next slide, please. Again, we found that women had worst acute treatment. It was found that intravenous alteplase was used in a window 2 hours less likely in women compared to men. And again, anticoagulants and lipid lowering drugs were used less frequently in women. And very interesting are the last 2 rows about the detected free measure and composite measure. When they analyzed the quality of care in patients, and it was found that in women there was a lack of some activities which should be done for the better outcome of the patients with the stroke. So from all what I told before, next slide, we can, and it was in all age levels. Next slide, please. From all what I told before, we can make the conclusion that there are 6 differences between the risk factors, but exist also the sex differences. What about the treatment? And it's time to change it, because our goal should be not only to prolong the life of the women, but we would like that the women are living long and in a very good quality of life. Like, for example, this lady who is around 85 years of age. And I apologize for my voice, but I am at the end of the COVID infection, so I'm sorry.
Well, thank you very much, Zuzana, for this excellent and comprehensive overview. Again, to the audience, if you have questions, please put them into the Q&A and we will address them after the presentations. It is my very great pleasure now to introduce Valeria Caso. Valeria is a professor of neurology and works as consultant neurologist at the Santa Maria della Misericordia Hospital and University of Perugia in Italy. She was the president of ESO, is a board member of various societies and neurologic and stroke journals. I can't list them all, there are many. Valeria has always been and is involved in multiple research projects investigating differences in stroke care of women, so she's an expert on this field. She is the international coordinator for the Working Group on Gender Inequality within the Horizon 2020 program, Prestige AF. And we are very much looking forward to hearing Valeria's opinion on how to increase female participation in RCTs now. Valeria, over to you.
Thank you, Silke, and thank you really much for this very kind introduction. So, these are my disclosure. And as you know, why should we care? So sometimes, you know, when I started to speak about women, and I always said it's so important because you have to be practical in life. Excluding, let's say, half or more than half of the population, you will have troubles, especially when we are thinking about drug development. And we saw, this is a report from the United States, that 80% of the drugs that were withdrawn from the market were to the side effects to women. So think about when you're doing a trial, how much work it is, how much cost, and you are there as an investigator, you are there as a patient to be involved, and everything. It's a lot of effort, financial, psychological, also organizational, to go through an organization of having a drug license. And I think this is something that it's not only, it's all the global situation of health. Also, when you think that a withdrawal of the drug means lack of trust. Maybe you remember all the discussion about AstraZeneca, the vaccination, how much it decreased the trust in science. So it's very important that we do good trials, involve the right patient in the right trial. So this was already addressed in 1993 by the NIH. There was some, especially for NIH funded trial, there was a request to have more inclusion of women, more inclusion of minorities, as this was already perceived as a big issue for trials. And the same was done by the European Parliament. And you see that this motion, I'm sorry for the little bit busy slides, that the European Parliament requested a better inclusion of women, especially due to the fact that, based especially in vascular disease, there was always already a sensibilization about the undertreatment of women in trials. And George Sigillos and myself, we did some analysis what it meant to have underrepresentation women in trials. So what we realized that, for example, maybe you remember, not all of you will remember, about the effect of thrombolysis in women. There was some let's say, unconscious bias saying, oh, thrombolysis may harm more in women. Then there was some report that it was even better to treat women. They have a better effect on women because maybe they have smaller vessels and so on. But when you put together the data, there is no biological difference in treating women. We are not talking about pregnancy and a special condition, but there's no difference. So it's very important that if you have the data, thanks also to the IST3 trial, which was the, let's say, most inclusive trial for thrombolysis, we realized that there was no harm and no special condition why women should not be treated, and especially elderly ladies. So this is a very important paper published by Cheryl Cassell and by Else Sunset and many other, and Peter, our moderator, our convener, that looking at all the vascular trials, that there was clearly an underrepresentation of women in trials, and you see especially in women below 70, which is, I think there is some reason for this, intracerebral hemorrhage, which is also one of my favorite arguments in stroke research. We see there seems to be less difference in acute trial, which is also easy to understand because in the acute state, there's not much time. Sometimes you have to say, okay, it's something that immediately can change your life, while it's much more difficult to involve women for longer controls and for having follow-up like 2 years, that they come back to all the monitor visiting and so on. And you see there's almost no difference about the regions. And so I believe that we really have a problem, especially we cannot afford that drugs are withdrawn from the market due to the fact that there are more harmful effects for women. And so we need to have a decision model. So we have to be, what I said, we defined the problem. I said, this is the problem, and we know it's not longer a question that women are underrepresented. And you heard this already from Zuzana. I think was showing, I didn't show you now the slides about the NOAC trial, but if you look at the NOAC trial, the women were all too young compared to what is normally going on. They were all underrepresented despite the fact that CHAS-WASC included female sex as an additional risk factor. So this under-involvement of women in trials will lead later to under-treatment. So it's something, if you know what you use what you know, and if you don't know the effects of a drug, then you don't use it. And I think this is a very good atlas of the Canadian Women's Heart Alliance, and where they show very well which are the different targets. And I will face only some of the targets which are more important for us in stroke medicine. As I said already, the women below 70 are less included. Probably, if you look at the broad group, especially when you think about the fact that women can be pregnant during a randomized trial, and you see that often you have long information sheet where there's explaining you that what kind of contraceptive drug you have to use, and you have to be careful not to get into pregnancies while you are on the trial. Same is for your partner. So it's something like, in a way, it's when you need all this information about the risk of getting pregnant while you're doing a clinical trial, then probably you will not say, okay, you will not be so happy to be included in this trial. But I don't think, and this is also, this is also due to the fact because we had this thalidomide tragedy. But if you think what it means, this was in the Grünenthal factory, let's say a company, did not really, they had some indirect data, they did not really include it, they did not really have this, let's say, this anti-nausea drug was used, especially in pregnant women, without data. So this is the fact. Again, we didn't have data. It was like sold like it's safe, because there was some evidence from the laboratory. There were no, they had some animal studies, but it was not really well enough studied. So this was in a way something that blocked many years the research on pregnant women. And I believe what was, let's say, what is now the tendency, and this is a very good article from Rieke van der Graaf, that women should be included. Not, there should be a reason why not include pregnant women in trials. So it's that we should not, or let's say, they should not be solely excluded for the fact that they are pregnant. And this is a way to have data. When I was pregnant 30 years ago, and I had to take, let's say, some paracetamol, even then it was, we know that there was no, let's say, that there was no side effects, but they looked at me, you should suffer, better not to take any drugs because you are pregnant, and so on. And or the other point is that we have to develop specific trials for pregnant women, because now what we know, don't forget that if you look at the data, the women are getting pregnant much older. They're over 40, which is fair, because women want to be they want to be now they want to study, they want to have steps for their career, which I absolutely understand. It was not let's say 30 years ago. Let's say it was not really, my pregnancy was not really planned, so I was very young, but this is not what we said, the normality. Now women wants to wait, and this carry more risk, because the older the age, you have more the likelihood to have some more vascular risk factors. So we have to be prepared also for this, and prepare our women and have data on these women. But the other, let's say, dark side of all exclusions of women are our elderly ladies. And our wonderful elderly ladies, which are, we know that there is a kind, especially when you look at countries like Italy, where we have a low fertility, and let's say we have this opposite population graph with old, let's say, a broad range of older patients. We have to take care of this lady, or we decide not to treat them, or not to have them coming to a good, let's say, age, and say, okay, they are out of our healthcare system. If not, we have to support them to be healthy and to have the best way of living. And we know also that when we exclude this kind of women or this kind of patient, and these are mostly women due to the fact that we tend to live longer, we have a quarter of, we have more in many trials, we have based on the inclusion criteria, we have 80% of the patient excluded, and this can go down up to 50%. So it's not something that we can afford any longer. When I started to do stroke trials, the age limit was 80, and after IST3, and now we don't have this upper age limit, which is clearly something in favor of randomizing elderly ladies, but still we need to support them. And this is even worse when we think about minorities, because now we will see also in Europe we tend to have more minorities. We will have refugees, and these women will be excluded. Now we have more data from the US, because there is already more sensibilization, but it's something that we also will need to face in Europe. And you see, it's not so much I think after all this Black White Lives Matter, luckily there's more sensibilization about patients of color, but we have an exclusion of the Latinos, which are now the most new target of patients which need to be included in trials. So again, targeted, let's say, campaign to get them inside the studies. You know, it's a lot of mistrust. So you need to understand what is the point, why our patients don't trust you and are not so willing to enter in the trial. Probably they feel in a way that they are not looked as white patients. They don't feel taken seriously as white patients. So often they cannot afford to pay for the medical services. Regarding this, I think one of the best trials which has been published recently is the SOSTART, because what did they do? They were very pragmatic. They included, you know, the SOSTART trial is, they compared anticoagulation with no anticoagulation after intracerebral hemorrhage. Beside the results, it's the design, which was, I think, extremely pragmatic, because they could, they allowed to enroll patients who did not have the capacity to consent, because also this, excluding patients who don't have the consent, the capacity to give the consent, means that you exclude patients who can benefit from trials, because clinical trials means you have a better possibility to be treated because you are follow-up. So it's very important that you include these patients. And again, we criticize them, besides that they did a wonderful work, due to the fact that they excluded again a patient with white. They included only white patient, and they did not include enough women. For the Prestige IF trial, as Silke already mentioned, we are trying to understand what we can do for this patient. We will have questionnaires for patients, for doctors, in understanding what is the best way to include them, because we will try to understand what are the inconveniences. For example, they have a lot of visits, how we can do it, how they feel when there's a forgotten appointment. Or what the other point is that the lack of appreciation of your work. So it's very important to keep motivated. So these are some strategies that we try to involve, to overcome fear, mistrust, to get to help them in their family care, to have mobile technology, partner education, or to have the engagement of the community and so on. So very important that you understand, you have to map what are all the issues in order to include more women. So this just to conclude. We need gender-based approach, dedicated awareness stroke campaign for women. So they have to understand they are at stroke risk. We have to include more women of above 80. And in some cases, we can stop also the male randomization when we have 50% of male, based on what is the impact of the disease in both sexes. So very important that we overcome what we call we need to de-bias ourselves, because when you give an algorithm, a computer, the inclusion criteria for a study, and probably this computer will include the women. If you as a doctor stay behind, look at a very fragile 90-year-old lady, she tells you with a low voice, very slow, you probably will not include her. So you have to de-bias yourself, because you as a doctor need to include a patient, because a trial is an opportunity for the patient, and it means that you can deliver better stroke care. Thank you very much for the attention.
Thank you so much, Valeria, for a really thought-provoking talk. I think I really look forward to discussing this more with you in the Q&A after. So for our final presentation of the afternoon, we have Professor Christine Kremer. Christine is Associate Professor of the Neurology Department at Scania University Hospital in Malmo in Sweden. And we owe Christine a debt of gratitude. She was the chair of the module working group for the guideline that she is about to present now on stroke in women. Christine has a special interest in acute treatment of stroke and on sex differences in stroke treatment and in outcomes. So it is my great pleasure to introduce Christine to present our new ESO guideline on stroke in women, management of menopause, pregnancy, and the puerperium. Christine, you have the floor.
Yeah, good afternoon, ladies and gentlemen, and thank you so much for the opportunity to present our guidelines on stroke in women, management of menopause, pregnancy, and postpartum. And this was our model working group, a large international group, and it was a pleasure to work with them and also the reviewers. And these are the disclosures, busy slide of busy people, but nothing in regard to the topic or of the guidelines. To start, this is the background. You heard a lot now this afternoon about the hormone replacement therapy. There is an increased vulnerability for stroke in women during menopause, as Theodore also pointed out, and there are conflicting results regarding stroke risk. And actual guidelines of the last years, they are lacking. And the other big topic of our guidelines is the stroke in pregnancy, postpartum menstruation. Regarding stroke in pregnancy, you've also heard this afternoon that it increases. It's widely ranging estimates from 1.5 to 98 at 100,000 deliveries, and the rate is around 30. Guidelines regarding the acute management with IVT and mechanical thrombectomy are lacking, mostly because pregnant women are excluded from randomized controlled trials. We developed this guidelines according to the standard operating procedure, and it's the GRADE approach, grading of recommendations, assessment, development, and evaluation. And we formulated 2 PICO questions, which are our main topics, the stroke in pregnancy and the menopause. Patient intervention comparison outcome PICO question, you will hear that in the next slides too. We identified the main outcomes and rate their relative importance, and we identified 15 critical outcomes. We did the systematic literature review for each of these 2 PICO questions with the 8 subheadings, and we assessed the risk of bias in each trial. And then we summarized the relevant evidence in GRADE evidence profiles. We did the meta-analysis, and then we graded the quality of evidence in very low, low, and high, and the grade of strength in weak and strong. And if it was not, the evidence available was not enough, we added an expert consensus statement, and we did the Delphi votes. And at last, we tried to reach a consensus among the model working group members regarding the guideline document. So these are our critical outcomes. Just remember, we have 2 main questions, the hormonal replacement therapy and the IVT-MT in pregnancy, postpartum menstruation. And for the hormonal replacement therapy, it was stroke all, ischemic, hemorrhagic, and mortality. Critical is the one that received 7 to 9 points, and the one with the 9 points are the most critical of the critical outcomes. For the IVT-MT in pregnancy is the modified ranking score at 90 days, and the mortality, the hemorrhage, the major bleeding, intracerebral hemorrhage, asymptomatic cerebral hemorrhage, intracranial bleeding, and all major gastrointestinal bleedings. And what is also important, the health of the baby, because it was not included in registries. Often they did not include the health of the baby and the type of delivery. For the hormonal replacement therapy, it was our first PICO. We had the question, and it's the PICO question, patient's intervention comparison and outcome. In postmenopausal women, does hormonal replacement therapy compared to non-prior hormonal replacement therapy reduce the risk of ischemic stroke in primary prevention? And in postmenopausal women, we suggest against the use of hormonal replacement therapy to reduce the risk of ischemic stroke, with a very low quality of evidence and a weak against intervention. Let me give you some additional information for this recommendation. This is the great evidence table for ischemic stroke. We included 6 studies, and I give you a short overview to the time, but 6 studies were included, and 3 were on hormone replacement therapy and 3 on receptor modulator. And they all had, if they were combined, a serious inconsistency, indirectness, imprecision, mostly due to wide-ranging odds, a large heterogeneity. And these trials were not designed for just capturing the stroke risk, but including different kinds of population, women with cardiovascular risk. The receptor modulators were designed for osteoporotic women. As you can imagine, the combined meta-analysis showed very low certainty, very low evidence, and the 2 on hormone replacement therapy and receptor modulator moderate. If you put it on the forest plots as the pooled odds ratio for ischemic stroke in postmenopausal women treated with hormone replacement therapy versus non-Breyer, this is ranging, but it's nearly neutral. There's some, as you heard today, the World Health Study with an increasing odds of 1.36. On the other hand, the receptor modulators slightly decreased stroke risk. In summary, the pooled odds was 0.97, which is close to 1. Remember that the quality of evidence is very low. For the next question, it was the hemorrhagic stroke in postmenopausal women. Does hormonal replacement therapy compared to non-prior hormonal replacement therapy reduce the risk of hemorrhagic stroke in primary prevention? In postmenopausal women, we suggest against the use of hormonal replacement therapy to reduce the risk of hemorrhagic stroke. Here we find a low quality of evidence and a strength of recommendation which was weak against intervention. For additional information, I show you the great evidence table for hemorrhagic stroke. These were combined 5 RCTs, which we couldn't include in our analysis. For the inconsistency indirect, it was not serious, imprecision, wide-ranging odds. It was serious, and for all is publication bias strongly suspected because it was lower than 6 trials included in the analysis. A hemorrhagic stroke with the hormone replacement, it was 2, and receptor modulator is 3. Receptor modulator on osteoporotic women, remember that. If you do that in the forest plot, it's 2 trials that had the endpoint hemorrhagic stroke. Otherwise, it was combined ischemic and hemorrhagic stroke. And this was also an odds that was for the receptor modulator slightly decreased, but 0.75, close to 1 also. So with the low evidence, it was nearly neutral. We asked the question, how could it be with secondary prevention? How could it be with an outcome of those women after their stroke? Does estrogen, progesterone, others have an effect in postmenopausal women on functional outcome? Or how does it impact the mortality? And the same we did with hemorrhagic stroke. And here we had, in postmenopausal women, we suggest against the use of hormone replacement therapy to reduce mortality. I have to add, there were no trials examining the functional outcomes as we did the screening. And the strength of recommendation, it was weak against the intervention. Here the pooled odds ratio for fatal stroke mortality with a very low evidence showed in the West trial, and that's what Theodore also mentioned. It was close to 1 in the odds, so it didn't really change the mortality or the fatality. So the next big topic was help, she is pregnant. There are many uncertainties about how to treat pregnant women, and often it's the pregnancy that is prioritized. I say you have to prioritize the health of the women who are pregnant and see them as acute stroke patients. And this is a multidisciplinary decision, so you have to involve multiple specialties, either by telemedicine or those who are in place. We had asked, this is the second chapter, in pregnant women with acute ischemic stroke, does IVTs improve outcome as compared to no IVT? And you can imagine that you don't find any randomized controlled trials that included pregnant women. So we didn't have the available data to make a specific recommendation. But we added expert consensus statement in the Delphi vote. And this suggests that pregnant women with acute disabling ischemic stroke who otherwise meet the eligibility criteria can be treated with IVT after appropriately assessing the benefit risk profile on an individual basis. I say this is a multidisciplinary decision. We are strokologists, but we can help to treat those women. The only registry we found was the one also cited by Zuzana this afternoon with Leffert et al. They included 40 cases that had a good outcome and good reperfusion rates and a slightly higher rate of interstitial bleeding. We additionally identified all case reports and this one registry, and these are the case reports. And in the case reports, it's important to say that they all also mention the health of the baby and the delivery, which are also a very crucial point in treating this woman. So of the 33 cases included, 32, and now it's one in red and bold, you have to read the 32 of the 33 cases, 97% improved or had a good recovery. And a healthy baby was mentioned in 28 out of the 32 cases, nearly 90%, which is important. And abortion or medical terminated pregnancy, 4 out of 32 cases, 13%. Interstitial hemorrhage, 3 out of 53 cases, 9%. Intrauterine bleeding, 1 case. The left side is the same for all. It's case reports and therefore low evidence, very low evidence in all of this studies. So the next chapter is mechanical thrombectomy during pregnancy. This is interesting because this is developing, increasing, and in pregnant women with acute ischemic stroke, does medical thrombectomy, intraarterial thrombolysis improve outcome as compared to no medical thrombectomy or intraarterial thrombolysis? We included also intraarterial thrombolysis because, as you can see, we are looking back the last 15 years and not just 4 years or 5 years after introduction of medical thrombectomy. And we had no specific recommendation to give because of the evidence was just case reports, not even registries. And we did that all members suggest that pregnant women with acute disabling ischemic stroke who otherwise meet the eligibility criteria can be treated with mechanical thrombectomy after appropriately assessing the benefit risk profile on an individual basis. And we added that in this woman with acute ischemic stroke to large vessel occlusion, if mechanical thrombectomy is available at that center, and mechanical thrombectomy alone should be preferred over IVT and bridging. If IVT just is available and not mechanical thrombectomy, IVT should not be withheld. A great evidence table for mechanical thrombectomy, intraarterial thrombolysis. We had 15 cases where just exclusively medical thrombectomy and the other ones combined. The 23 cases which showed an excellent recovery for the mother in 23 out of 23 cases, and a healthy baby in 18 out of 19 cases, so over 90%. Abortion, one of 19 cases, interstitial bleeding, 2 out of 23 cases, so it was quite low, and no case of intrauterine bleeding. The IVT during postpartum, and now it's just case reports, so no great evidence table. In women with acute ischemic stroke during the postpartum period, does IVT improve outcome compared to no IVT? Few case reports, 5 that we identified, and those after 10 days after delivery, so not directly after the delivery in the first 3 days. There is no case published, and within 3 months. So in this period, all members suggest that postpartum women with disabling ischemic stroke occurring at least 10 days after delivery can be treated with IVT with alteplase. The same, you have to assess the benefit risk profile of each patient. And mechanical thrombectomy during postpartum, 3 cases in women with acute ischemic stroke in the postpartum period. The period is defined as before, after 10 days, and within 3 months after delivery. Suggests that all members suggest that postpartum women with disabling ischemic stroke occurring at least 10 days after delivery, who otherwise meet the eligibility criteria, can be treated with mechanical thrombectomy. And a majority of members suggested that if medical thrombectomy alone is available, it should be preferred over IVT and bridging therapy. So the last of our PICOs, the 2.5, was the menstruation. And this was very interesting, actually, with 6 cases in the NINST registry. And I was wondering, there are so many menstruating younger women, why are there just 6 cases? But it was available data that do not allow. Have we excluded them from all randomized clinical trials because they were menstruating? Never know. But this is an exclusion criteria too. And all members suggest that women with acute ischemic stroke during menstruation who otherwise meet eligibility criteria can be treated with IVT. Those 6 cases had an excellent outcome. To conclude, I say this is a neglected area of research. Looks like all patients for the menopause and the hormone replacement therapy were included in the 90s and 2000 with a dosage that was at that time modern, and they have changed, and the application mode has also changed. So we really need more RCTs on this, because in the future, postmenopausal women will also be treated with hormonal replacement therapy, and the risk profiles are changing. And we need more subgroup analysis of potential risk groups. And regarding the IVT and mechanical thrombectomy during pregnancy, postpartum menstruation, this is also obvious that we need more registries, and we need to include more women into registries for defining risk profiles and profiles for prevention for ischemic stroke and pregnancy postpartum. Summary conclusions: we find low to very low evidence in all recommendations. 5 expert consensus statements in IVT, mechanical thrombectomy, pregnancy, postpartum menstruation will hopefully help the clinicians to guide in everyday practice and care of these women, and maybe also be more proactive. And the guidelines highlight the need to identify evidence for stroke prevention, acute treatment in women in more vulnerable periods of their lifetime to generate reliable data for future guidelines. Thank you very much for your attention. I would like to thank everybody from the ESO, Julian Talk, Simona Sacco, the Guideline Committee, and Lucia Balma, Sabrina Mutter, and the others, Yvonne, from the headquarters. I would like to say we have a study that is the WISE study, and please, if you have women in pregnancy, postpartum, include them. You can mail us. Thank you very much.
Well, thank you very much, Christina, for this very interesting presentation of this new guideline. We are very happy to have this new information available, which will certainly help us to treat and deal with everyday questions. I can see many questions in the Q&A section. That is wonderful. I would like to start with some questions to Theodore. Theodore, there is a question regarding the risk of stroke in reproductive age. This is lower in women of younger age compared to postmenopausal women. The question is, if this is due to the protective effect of endogenous estrogen, then why does exogenous estrogen administered with hormonal replacement or with contraceptive treatment, why does this increase the risk in stroke? Can you explain that a bit further?
This is an excellent question. It's a very logical question. The truth does not lie in the fact that we have a single protective substance, and that is estrogen. Estrogen is a whole family of hormones. And we don't have just a hormone, we have a whole interplay between sex hormones, between estrogen, estradiol, testosterone, other sex hormones, the other hormones. So it's very much complicated physiology during the reproductive life of a woman. When we administer exogenous hormones to a woman, we administer a single agent, a single hormone in a fixed dose, and this does not replicate the human physiology. So it's a totally different thing. We cannot simulate or we cannot replicate the female reproductive physiology by administering an exogenous agent. And the data and facts speak for themselves. It's dangerous, it doesn't work, so we don't do it.
Thank you very much. And there's another, a bit more practical question. How would you approach a situation in which you know that a woman does need hormonal replacement treatment, but for another reason, like endometriosis, for example, how would you manage that in your everyday clinical practice?
If there is a pathology or a medical need for a hormone replacement therapy, then the best way and the safest way to do it is either to administer progestogen only contraceptives or hormone replacement therapy, which seems to be safer, although data are limited, or if you have to use a combined COC, a combined hormone replacement therapy, estrogen plus progestin, then try to use a formulation which has the lowest estrogen dose, because as I showed you, stroke risk is dose dependent. So we tend to use the lowest estrogen dose available if this is practical and feasible from the point of view of the other medical pathology, in order to get a protective effect.
Thank you.
Thank you, Theodore. So this one is for Valeria, and it's from Rustam Al-Shahi Salman. And just to paraphrase, Rustam says, thanks, Valeria. So why do so many secondary prevention trials under-recruit women? And in Prestige AF, what is the male-female ratio, and what are your strategies to try to improve this?
Thank you, Rustam, for this question. So what I can say that we still are struggling. We are, let's say, around 30% as you were, but we are still on track. Now we are starting with this, what I said, questionnaires. We're sending the questionnaires to understand if there's really a gender bias. So we need to understand what is if the same patient, 90-year-old, female or male, creates more insecurity, because it's, you know, the action between doctor and patient is a mutual trust. So if you feel that it's something that you cannot trust this woman because she has more, she lives alone, she has more, let's say, cognitive impairment compared to a man, and she has not a partner. This is what I said before. She lives alone, so there's no women saying, "Did you take your pill? Have you taken your pill?" and so on, which makes a huge difference. So this is something, and then we will also do interviews for the patient. Based on the results of this interview, that we will have some tools more in order to involve patient in the randomization, because we have to unbias doctors, but we have to unbias also the patients.
So you think it might be a combination, perhaps, Valeria, of us as investigators,
yeah,
but possibly also patient choice, particularly for these follow-up visits. We certainly need more data on this. We're seeing something very similar in our trial, Convince. So just to follow up on that one, Valeria, because it's such an important and interesting question. So this is from Milan Joshi. And again, I'm just going to paraphrase Milan's excellent question. So Milan is suggesting that to achieve gender balance, rather than simply stop recruiting men after 50%, would a bias coin approach be perhaps better, whereby the randomizer corrects for the imbalance increasingly to create that balance? So that's a very good suggestion, I think. What are your views?
Yes. You know, when we wrote this editorial, we wanted to, as everything it's an editorial, it was not based on science. So we said, okay, let's say we have to change something. Sometimes, you know, it's the same question when you said gender quote. Why do we need gender quote? Because we don't, honestly, I do not know any woman who likes gender quote, but it was important to start from somewhere. So say, okay, you have a limit, 50%, then you stop. But if there is something that we can correct, and if there's a better awareness about what is not going right, then we can say, let's make this approach much more tailored in order to have good numbers and the right patient for the right trials.
Thank you very much. I've got one question here for Zuzana. Zuzana, the question is, can you explain a bit more why women are not properly anticoagulated? You explained that it seems that women do have less contact to their doctors, but can you explain whether there are any other reasons for that?
Probably it would better explain people who undertreated these women than me, because I think that the women should be treated as men. And as you mentioned before, or now you mentioned that they are underrepresented in trials, when we are speaking in trials, and in everyday life. It may be the question, how is organized treatment of women in different countries? Because we know that in some countries there are differences how women can visit the doctor, and more frequently men are visiting doctors than women. We are not speaking only about the Europe and US, but also of all the other countries. And when I read these articles, I saw that in some countries, woman cannot go to the doctor without her husband, and when he doesn't go with she, then there is the problem to treat this patient. So I think that it is also this reason. And in the countries where there are no these problems, we can do our best to increase the number of women who are treated.
So what can we do? So what could be our approach to make that better? So each and every time we see a male patient, we have to ask, can you bring your wife the next time you come? Or
so I think that everybody, it doesn't depend if it is woman or man, everybody should be treated as guidelines recommend to do it. And so we do not exclude women from this. And then maybe we achieve the balance between men and women, how they are treated.
Thank you.
Thanks, Zuzana. So this next question is for Christine, and it comes from Sofia Mavromati. And Sofia says, thank you for a very interesting seminar. And she has an interesting question here. Are there any data concerning the safety of IVT or thrombectomy stratified by the trimester of pregnancy? In the review of the trials and the literature, did you come across anything there, Christine?
I can say that those from the guidelines registry are mostly in the first trimester, but this would be interesting to do, but there are not too many patients to have them stratified. Those mentioned are the majority are in the first trimester, actually, of those we have.
Yeah,
included.
We just need bigger, robust registries, don't we? And then there's another interesting question here. This is a little provocative, perhaps, but very clinically relevant. And it's from an anonymous attendee. What about stroke in the postpartum before 10 days? Do you have any comment?
No, we have discussed this in the group, and I think Zuzana, who was also main responsible for this PICO, we had discussions how we, because we were looking through the literature and seeing that it was after 10 days. So so this is something to do actually, to include more in this first week. I think this has to do with the placenta and the high bleeding risk, and nobody really want to risk something, so that therefore no case was published, and I doubt that it's administered.
Based on your expertise, Christine, would you feel comfortable recommending EVT in a patient, young female patient with severe stroke in the first 10 days? Not an official ESO position, but just
we had this elegant solution that we said it's mechanical thrombectomy. In those cases, and I think this is something to think of, because the etiology is mostly embolic, and it's even thrombectomy in mild strokes with distal M2 occlusions. So yeah. I think maybe we just do skip the IVT and go directly to the next chapter, hopefully. And then I have to underline that it's also the gynecologist and obstetrician we have to talk to. And this is something crucial in this period.
Thank you very much. There is one also very practical question, probably to Theodore and also Christine. So when a lady needs HRT, would you add aspirin? That is a question regarding primary prevention, risk of stroke with HRT. Theodore, do you want to start? What would you do?
We have absolutely no data that adding an antithrombotic treatment to a woman under HRT benefits or harms the woman. So the best way to prevent or to minimize stroke risk is not to expose a woman who does not need it to HRT, or to use the lowest possible dose of estrogen. But I would not feel very comfortable adding aspirin and adding another hemorrhagic risk to the risk of HRT. No.
Thank you. And I think Christine, also the module working group worked a bit on the primary prevention data available for the primary prevention in general. Do you want to add this information?
No, I just see we're nearly closing. We have 2 more minutes, and I have to keep it short. We need more data. We can't really combine this. I don't have right now. It's we have to stratify the risk profiles of those women that have hypertension and other vascular risk factors. I wouldn't automatically give aspirin now.
Thank you.
Okay, I think we're coming to the end, and just really to thank all of our contributors this afternoon, and in particular to thank the module working group for this guideline. which I think is hugely welcome and will be very useful in clinical practice. So we really appreciate all of the work that you have done. We thank you all for your attention this afternoon and for joining us. And we wish you a good evening. Thank you again.